Welcome to the OMMedicine's module on immune thrombocytopenic purpura. Immune thrombocytopenic purpura, or ITP as we will refer to it from here on, has several different forms. However, the one that you are most likely to be tested on and the true autoimmune form is going to be what we call primary ITP. Now, primary ITP is considered an autoimmune condition caused by the development of autoantibodies against the GP2B3A receptor on platelets. Now, we won't go into all of the pathophysiology and different receptors located on platelets in this module. However, it's important to know that the reason we develop thrombocytopenia in ITP is because we have antibodies against the GP2B3A receptor on platelets, and that's going to cause these platelets to be absorbed and sequestered by splenic macrophages, which will ultimately cause destruction in the spleen and therefore a low platelet count. There is also something called secondary ITP, which is ITP associated with another condition or an inciting event, and those associated conditions tend to be relatively high yield for your board exams, so we'll go through what conditions are associated with secondary ITP in a couple slides. So now let's talk about the typical presentation of a patient with ITP, and it does not have a specific age range. It can be seen in both adults and children. And we will have thrombocytopenia, so you would of course expect to see some form of bleeding. Now, nosebleeds or epistaxis tend to be one of the more common forms of bleeding seen in these patients. However, you really can have any form of bleeding. And as the name implies, in immune thrombocytopenic purpura, we would expect to see petechiae or purpura, and then we can also see some non-specific findings like fatigue. And one clinical pearl I want to point out, especially for your board exams, is if you see a patient develop bleeding and thrombocytopenia shortly after starting heparin, it's more likely that that patient is going to have HIT or heparin-induced thrombocytopenia rather than them spontaneously developing ITP after starting heparin. And one other clinical pearl I would like to point out is that if you see a patient who has thrombocytopenia and anemia and leukopenia, meaning that they have decreased levels of platelets, white blood cells, and red blood cells, then your concern for myelofibrosis or myelodysplasia should be higher than the concern for ITP, because as we'll talk about in a minute, ITP is typically going to have a normal white blood cell count and a normal red blood cell count. It's only going to be platelets that are affected. And this should make sense to you because remember that in ITP, we're making autoantibodies against the receptors on platelets, which will then be sequestered by splenic macrophages and then ultimately destroyed in the spleen, leading to thrombocytopenia. We're not making any autoantibodies against red blood cells or white blood cells, so those levels should be fine. Whereas in myelofibrosis, we have destruction of the bone marrow, which will affect all cell lineages. Now let's move on to how we would actually diagnose a patient with ITP. And so as we will always do, we will get routine labs, and we would expect to see thrombocytopenia, hence the name. So we would expect to see a platelet count less than 100,000. And the reason for thrombocytopenia is going to vary based on what form of ITP we're talking about. And as we've mentioned several times, in primary ITP, we're going to have antibodies against the receptors on platelets, which are then going to ultimately be destroyed by the spleen. And in secondary ITP, we're going to have a medication or infection or an associated condition that helps result in the destruction of platelets. And as I mentioned on the last slide, we would expect to see a normal red blood cell count, white blood cell count, and then also a normal PT and PTT, because remember, this is going to be a disorder of platelet destruction and not a disorder in the coagulation cascade or of any of the factors in the coagulation cascade. Now, a peripheral blood smear will also typically be performed in the diagnosis of ITP to make sure that the thrombocytopenia is a true thrombocytopenia and not due to pseudothrombocytopenia, which is caused by clumping of platelets, which result in a lower number on labs. However, you will see large clumps of platelets on the smear, which would indicate that the platelet count is typically normal. They just tend to clump together. And on peripheral smear, we will also look for things like abnormally sized platelets, whether they're very large, and this would indicate some genetic disorders, which we cover in some of our other modules. Now we need to mention some of the associated conditions with ITP that I previously mentioned, and the two very important conditions that all patients who have a suspected diagnosis of ITP need to be tested for are going to be HIV and hepatitis C. And this is a very commonly tested point for your board exams, so if you have a patient who has a clinical presentation of ITP, it's very important to know that you also need to test these patients patients for HIV and hepatitis C as well. Some of the other conditions we can see associated with ITP are CLL, or chronic lymphocytic leukemia, lupus, and then infection with CMV. Now, the official diagnosis of primary ITP is a diagnosis of exclusion. So if we have a patient who fits the clinical criteria for ITP and their labs are consistent with ITP, we need to rule out all of the other associated conditions that could be causing it and make sure that there are no drugs that are causing thrombocytopenia, as well as making sure that we get our HIV and hepatitis C testing. And if all of these are negative, then we can go ahead and say that the patient has primary ITP. Now, one very high yield point for your board exams is that in order to make the diagnosis of primary ITP, we are typically not going to test for those antiplatelet GP2B3A receptor antibodies. Now, your board exams may give you a clinical scenario in which a patient has ITP and ask you what the pathophysiology is behind this condition, at which point the correct answer would be antiplatelet antibodies. However, these are not typically tested for in order to make the diagnosis of primary ITP. Now let's talk about the management of patients with ITP. And for children who have this diagnosis, there's no real treatment because most of the times it's going to resolve on its own. The only time we will treat children with ITP is if there is a planned surgery in the future or if they have a severe bleed. For adults, if they have a platelet count greater than 30,000 and there's no current signs of a bleed, then there would be no indication for treatment and we can just watch these patients. Now, for adults with a significant bleed, then we would want to treat them with IVIG and steroids, and then if their platelet count continues to drop, then we would transfuse platelets as we would for any other patient. Now, if a patient has recurrent episodes and is frequently bleeding and is really symptomatic, you can consider a splenectomy because remember, we are thrombocytopenic because the platelets are going to be destroyed by splenic macrophages, and so if we were to remove the spleen, we would increase our platelet count and hopefully have less severe symptoms and less bleeding. And that brings us to the end of this module on immune thrombocytopenic purpura.